Thank you so much for coming to the panel. This is the Rural Health panel. I couldn't remember the name, to be honest. It's quite long. But we have an amazing panel today. I could not ask for a better panel than the three experts sitting here. So I'm going to introduce each of our panelists. If I let them to introduce themselves, they're probably going to be really, really humble, not stating all the achievement they have. So I'm going to sort of try my best to tell you who they are, and you will be amazed. So starting from Mr. George Leon. All right, so he's a senior manager of global healthcare workforce strategy and programs within the Global Health Equity Organization at Johnson & Johnson. George plays a pivotal role in advancing the company's global health equity mission with over 2 decades of global leadership at Johnson & Johnson and Johnson & Johnson Foundation. He has led large-scale programs, managed high-impact partnership, and built innovation frameworks to ensure measurable outcomes for people and the community worldwide. He holds an MBA from UNC Chapel Hill and a bachelor degree in industrial and system engineer from University of Florida. All right, so welcome, George. And next we have Dr. Lynn Nowak. She's the SureScripts first Chief Data and Analytics Officer. She has held multiple senior leadership roles before taking that position in various industry related to healthcare. She has overseen hundreds of $millions in investment driven data strategies and advanced digital solutions to improve care for patients and providers and peers alike. And she also has been involved in numerous efforts mentoring and encouraging girls and women in STEM. That's very important. As an educator myself, I find that's really, really great. And also mentoring emerging business leaders in healthcare. Dr. Nowak holds an undergraduate degree from Notre Dame. Okay, go Irish. And MD from the University of Illinois. And she began her clinical career with a residency at Mayo Clinic and spent 50 years practicing as a certified internal medicine physician. So welcome, Lynn. And lastly, we have Dr. Cami Wright. She's now the market president for CareSource Indiana, where she oversees health plans and focuses on expanding access to high-quality care, especially for individuals with complex medical and social needs. She's a physician, execute for over 20 years of experience in medicine and Medicaid, affordable care, and population health. Prior to her current role, Dr. Wright was the chief medical officer at CareSource Indiana. She has championed maternal and infant health, built collaborations that strengthen health systems across the whole state of Indiana. Dr. Wright received her undergraduate medical degree from University of Michigan, and go blue because I graduated from Michigan.
Oh, wow.
And her master's degree in business administration from Indiana University. Okay, this is a time that if you have any disclaimer to make, this is the right time. No disclaimer whatsoever. All right, okay. So we're gonna dive right into the questions. I do have some questions for our panelists, and but we will save about like 3 to 5 minutes at the end for the audience to ask any questions you have to our panelists. So I'm gonna start with a general question. So because I'm a statistician, I work with data all the time. So my first question will be, the data in rural communities are often siloed and incomplete and really hard to standardize. Based on your experience, what are some of the most promising strategies you have seen that to overcome this kind of data challenges? If you have not seen such sort of good solutions, maybe you can tell us a little bit what we should do in order to make the data high quality.
So I'll just jump in and start. I would agree that the data is absolutely siloed. And what we find is that multiple rural facilities have different EHRs. Those EHRs don't speak to each other. They oftentimes don't speak to other data platforms. And so there's a house of Babel, if you will, with different systems that don't communicate with each other. They oftentimes aren't necessarily on the same version of EHRs as some of the other facilities that are in the more urban areas. So that oftentimes can make data exchange difficult as well. There are a couple things that I see that are promising. One is iHi, which is the Indiana Health Information Exchange. We're very lucky in this state that we have a very robust health information exchange that can serve as a repository for that data and allow data to come into and flow from rural institutions. There are some challenges with that, however. It does require either logging on to a separate platform or purchasing a API in order to integrate that into the EHR, and sometimes that can be cost prohibitive.
Yeah,
Our FQHCs use another platform called Azara, which helps to collect data, and we as a health plan integrate into Azara. And so for those FQHCs, particularly those that are serving rural communities, that data platform and integration with the health plan really helps to drive quality and some of the value reimbursement initiatives that we're doing.
that's great. Yeah, I'm so glad that we do have solutions. But Lynn, you have anything to
Yeah, I would just add, I think there are a couple other shining lights of hope out there. It is certainly true that interoperability is not where any of us had hoped it would be today. But the interoperability legislation, or I say regulation, that has happened over the last, say, 5 years, I think has helped move things in the right direction, and more standardization of data. While we have a long way to go in healthcare, um, going towards fire standards and other, more standardized elements of data requirements for those exchanges, that I think is moving us in the right direction. Initiatives like TEFCA, adoption of QHINs, the Qualified Health Information Networks, and now, the even the newer versions of interoperability, I think is at least moving us in the right direction, albeit slowly.
That's awesome.
And then, I would just add from a funder perspective, we work with a lot of impact focused entrepreneurs and also nonprofits that work in this space, both in the US and around the world. And what we have funded and found to be very effective are funding the integrations into the systems so that as particularly in the US, as FQHCs bring in new capabilities to work with their patient populations, all the data that's incoming can be integrated into their into the electronic management system. The other piece, which we try to think about as well with all the folks that we work with, is taking a sort of a clinician first perspective as they're designing innovations and systems. So don't think about what tool do they want to develop, but think about what's the problem that they're trying to solve from the frontline healthcare worker perspective. So is it the community health worker? Is it maybe the nurse that's sort of at the point of care and designing tools that will support them? Because often you'll realize through that design process that the information silos that you might unintentionally be creating with some of these solutions.
Wow, that's awesome. I didn't know all of that. So that's good to hear. And we have solutions in place and more promising solution on the way. So that's actually sort of brings me to the next question, with regard to healthcare innovation. So many of you aware that payment and the reimbursement system also lag behind healthcare innovation. So how, in your opinion, how can data and analytics can help to demonstrate the value of sort of this new innovation in rural health, maybe in a way that can accelerate the adoption of those innovations?
Yeah, I'll jump in there with one thought. When we talk about some of the challenges, I mentioned things like QHIN, Qualified Health Information Networks, TEFCA, and the like. One of the real challenges there is the information flow is largely limited to treatment use cases. Now, there's a lot of really good reasons for that. We obviously, whenever we're getting data more accessible, you have to really be cautious about patient privacy and security. And so that's, I think, why it's been narrowed to those treatment use cases for now. But it also really creates more limitations in what you can do on the payment and operations side, which is where there's so much inefficiency, patient friction, provider friction. So one example. prior authorization. Who loves prior auth, right? I've spent the last, I'll say I've spent the last decade of my career trying to solve prior auth and automating prior auth. It is the burr under my saddle, if you will. And the data and technology are available. It's not that complicated. It's not easy, but it is a fixable problem if we could get the right data to flow to the right entities who need the information to approve or deny the prior auth quickly. At SureScripts, I won't make this a commercial about SureScripts, but we're really excited that we're doing a lot of really great work with automating prior authorization by pulling out the clinical criteria required by the pharmacy benefit manager, coupling that with information that we're pulling out of the FHIR servers at the EHR, marrying that together, working with the PBMs to automate their approval process. And we can take what it is currently a anywhere from days to weeks process to get a medication approved to 30 seconds. So that's just, I think, one glimmer of hope that there's a lot of really great innovation work to help streamline some of these really inefficient processes right now.
That's really encouraging.
I can. Oh, go ahead. No.
Oh, okay.
Yeah.
So from my perspective, as a health plan, value-based reimbursement is where it's at. And that is something that I don't know has quite lived up to the dream yet. So what we ideally want to do is to link reimbursement to the quality of care, right? And I think that that's really critical throughout our communities, but particularly in rural communities where there's access, availability, and quality issues. In order for value based care to be effective, it has to be informed by data.
Yeah.
And so you have to have data about the utilization of services. That data has to be agreed upon by both the payer and the provider. And then reimbursement obviously is generated from that point. I think that we are still, as a country, in a rudimentary stage with that for a variety of reasons. I think one of them, and probably the biggest one, is what we're gathered here to talk about now is data. I don't know that we necessarily have all of the data that we need in order to truly inform those reimbursement strategies. I think oftentimes there are disputes between payers and providers in terms of what care has actually occurred. I think care is often fragmented. So, a member may be getting care at 3 or 4 different places. If those systems aren't integrated, then you don't have a full picture of that care. So, all of those things obviously are very prominent issues for rural communities. And I look forward to innovation to solve for that. So I think that there are opportunities to integrate that data in systems that can be utilized for population health and also reimbursement.
That's great. As a researcher, I love to hear that. There's still a gap you need to fill. So that means innovation for sure. Yeah, George.
Did you want to have something?
Yeah, I just want to add one other thing on the value-based reimbursement. Another piece of the data that's often missing is helping the providers have the right information and data they need to make the best decisions at the point of care. So, having been a practicing physician, you're making decisions with incomplete information too often. So, getting more information to the doc, things like what will this procedure cost? Will this medication be covered? If it's covered, how much is it going to be? Can my patient afford it? Those kinds of data-driven decisions at the care level is where you're actually gonna help those docs succeed in those value-based reimbursement arrangements, but more importantly, they're gonna even be giving better, higher quality care to the patients with better outcomes, which at the end of the day is what the payers wanna pay for. So it all is sort of this virtuous circle of having the right data in the hands of the right people to make good decisions, whether it's the payer, the provider, or even the patient.
Yeah, yeah. I agree 100% with both your comments. And just to give a couple of examples, the data is critically important for all of this to work, and value-based care is where everything is moving. We have been supporting a nonprofit called Care Message, just to use as an example. They provide SMS text messaging to capabilities to FQHCs. And they've, with using the data that they provide through the text messages, that they've done randomized controlled trials showing like a significant decrease in no-show rates. They show a significant increase in screenings for cervical cancer, for breast cancer, and all of these things. That they collect all this data. It makes the FQ. It leads to improved health outcomes for the patients. It leads to better utilization of the FQHC. We know there aren't enough healthcare providers, so whenever a patient misses an appointment, it's a huge issue for the system overall. And then it lets them get reimbursed in a more effective way. So just an example of how valuable the data is in the system, and being able to capture it, being able to apply sort of the
Yeah.
statistical analysis to it, do the studies, and get the data really improves the whole health system. And then the only other piece I'll mention is it's an interesting stat. This is something we captured on with community health workers in the U.S. They spend about 30 to 60% of their time on administrative tasks. They're not helping patients, which is really why they're in the business and why they became a community health worker. So the better we can use technology, use AI, use data to help them inform and handle sort of getting reimbursed in that whole process. Again, just increases the capacity that they have to support patients and really help their communities overall.
That's great examples. Yeah. All right.
I would
Yeah,
I
go
would
ahead.
just add because you made me think about care managers as well.
Mhm.
So our organization depends very heavily on care managers. They're nurses and social workers who engage with our members and help them navigate the system. And in a similar fashion, they spend so much of their time trying to track down the member and then doing a variety of assessments, much of which is redundant. And then, using that information to think through what the next step should be. And I think that AI, and I'm sure we'll get to AI, would greatly help in that setting. And I think for rural individuals who perhaps have a greater set of needs,
Yeah.
it's that much more important.
Mhm.
Great. Yeah, completely agree. So, I mean, all of you mentioned about the fragmented or incomplete data, and I mean, when we talk about data, usually we talk about like maybe claims data and the registry or lab data or EHR. Is there any sort of like a surprising data format you see? For example, could be storytelling, right? So I could use large language model to extract information from the stories, and maybe there are other sort of really surprising data formats you never realize that can be integrated in today's AI and the data framework. I'm not sure if that's something you ever seen in your experience.
Yep. So I think we classically talk about nothing about us without us.
Yeah.
I think that it's really important to understand from residents in rural communities what they need. And one avenue is storytelling, another avenue is needs assessments. So I know that there are multiple community organizations that formally assess for the needs of their community. And then that data can be taken and aggregated and used to inform resource development and interventions. So I don't know that that's surprising, but I think that that's an important advancement that we're not just looking at objective data, but we're factoring in that subjective information as well.
Yeah, that makes sense.
Yeah, I'll say one of the areas that we really like to focus on is from an access perspective is how do we really help enable all clinicians to practice at the top of their license. So when you think about particularly in rural communities where we saw stats yesterday from I think it was from the Ascension ladies that 124,000 person physician shortage coming, and we know there are even fewer nurses. I mean, there's these enormous clinician shortages, and there are pharmacist shortages as well, but there are more pharmacies, and patients are very likely to go to their pharmacy in rural communities, and pharmacists are very trusted. The challenge is how do you enable the pharmacist to actually help with more clinical care and not be so bogged down by administrative burden? So again, a lot of the work we're doing is how do you it may not be fancy LLMs, or I mean we're doing a lot of stuff with the more sophisticated AI, but even just good old fashioned automation, as I mentioned, automating prior auth. It's how do you free up these administrative tasks? How do you get clinicians back to actually taking care of patients, whether it's a doctor or a nurse or a case manager or a pharmacist. And that's where I think AI can really take a lot of that operational efficiency, just task work that a well-trained clinician should not be burdened with, so they can actually get back in front of a patient.
Yeah,
Yeah.
sure.
Yeah. All right. So I mean, yeah, we're sort of like going to the questions and discussions about AI, and as alluded to, seems like AI is now something that nice to have for from a long term perspective. Is something that we must do in order to win. Do you agree with that, or like, do you have any sort of statement to reinforce that kind of opinion, or do you think, oh, maybe you just wait and see?
I think it's an absolute. I think
Absolutely.
it's
Yeah.
coming. I think that there's no avoiding it, nor should we try. I think I love the term responsible AI
Mhm.
because I think that that's what's really critical. We need to have a human in the mix at all times. We've talked at this conference in the past about equity. I think that AI is only as good as the data that informs it, the data that sits behind it. And so we need to make sure that that data comes from a robust, diverse population, so that it can make the best observations and insights from that data. But I think that it's unquestionable the fact that AI will help us.
Yeah.
Mhm.
I think not just in terms of sort of data collection, but helping us understand the data and helping us gain insight into the populations that we serve. We use predictive analytics to determine not just how someone is doing today, but how they may do tomorrow and what that behavior might look like. And I think AI is a critical tool in that realm. We talked about care management. I think care management could be so much better with AI in the background, just in terms of even the tone and the approach that you take. So if you're talking to a 25-year-old, you may use different words, you may use different analogies,
Yeah.
you may use different motivations than if you're talking to a 65-year-old.
Yeah. For
And
sure.
I think when a care manager is on the phone, the ability to have those insights at her fingertip, I think is really critical. And then lastly, we want to make sure that everything we do matters. And so we want to make sure that we're tracking outcomes and we want to make sure that everything that we're doing is getting us to better health for our community. And I think there's a role certainly for AI in helping us make those determinations.
Awesome.
Mhm.
Yeah.
Yeah, I
Very.
I would say so, yes. I'll say yes and. I think it's something we absolutely should embrace. It's also something that we should proceed with caution and recognize, not to be afraid of it, but recognize where we are in just the big picture of the AI journey. It's amazing. It's incredibly powerful, and it's also not magic, which when we talk with our CEOs and our boards and the people who watch CNBC and come in and say, you should be doing more with AI. What are you doing with AI? Like, I was at a CEO conference and, everybody's doing cool stuff with AI and we're not doing enough. Go do more. And I'm sure I'm not the only one who's having those conversations, right? And it's not magic, and it is an emerging technology that is incredibly powerful, and we should absolutely leverage it. But when you're talking about healthcare, we need to proceed with caution. This is not the same as, running your supply chain. This is not the same as shortening time on a call center phone call. If we screw up, people get hurt.
Mhm.
People die, and that needs to be taken very seriously. So I think it's not to be afraid. It's not. It's to embrace it wisely and have a human in the loop while we're still learning and understand where it's appropriately applied and where we might want to wait a little bit till it gets better. And I think it's particularly important that we proceed with caution when we're talking about rural healthcare
Mhm.
and solving for patient access problems, because it's very tempting to put a rural patient with behavioral health issues, on a telehealth call with a bot.
Mhm.
Mm.
That's a problem, right? That is not like we're not there yet. These capabilities are not to where you can just cut them loose and it may feel like a quick fix for a big problem, but we're not quite ready for that yet.
Yeah.
I believe we'll get there
Yeah.
at some point, but this is all still very new.
Great. Okay.
Yeah. So I agree with both, everything you both said. Two interesting use cases, just sort of making the case for AI in healthcare. The company I mentioned earlier that's using the SMS messaging with FQHCs, they can have a whole conversation now using AI and LLMs to reschedule someone for their appointment. Very low risk to your
Yeah.
point. I mean, no one's going to die if,
Right.
if they misschedule their appointment, but it lets the care managers and the people working in the FQHC focus on other things, focus on patient care while the AI is managing the scheduling. Another example that's not in the US, but in Kenya, there's a company called Penda Health. And what they have done, they've integrated AI into the patient records. So when the doctor goes in and says, here's sort of the symptoms that the patient presented with, and here's what I'm prescribing, there's a little button that will light up red, yellow, or green. And it just, they can click on it and it will tell them how does what they recommended based off of how the patient presented, how does that compare to the evidence-based approach that is sort of like the textbook recommendation? Now, the physician has 100% capability to override that, but it's sort of just looking over their shoulder and saying, hey, did you realize, the evidence says you should do X, Y, and Z, and it just brings it to their attention. They did a survey, and it was a little bit over 70% of physicians said that it significantly increased the quality of care that they were providing to their patients. And it also significantly decreased the amount of antibiotics prescribed. So really interesting, but obviously human mediated. It's a helper. It's not replacing humans, but still being very helpful in the process.
That's a very
So
interesting app. Yeah.
So that's clinical decision support, which is something that I think is incredibly exciting.
Mhm.
For practicing clinicians, it's almost impossible to know all of the literature. Even if you're very diligent and keeping up with your reading and going to conferences, there's still going to be things that you may not appreciate. There's still going to be a note that was hidden in the chart that maybe you didn't see that might have changed your decision making. And so I love that aspect of AI. Of course, the clinician still needs to think through whether this is the right thing, but I think that extra support is really, really helpful. I think another space that can be used in is utilization management, going back to the PAs. So if a request doesn't seem to meet criteria, it goes to a physician to review. The physician is tasked with going through the entire record of that patient to determine the relevant factors that may assist with that decision. That can be really onerous. Again, things can be missed. And I think that that's a space where AI can summarize the chart or to find, yes, they really did have a hemoglobin A1C. Yes, they really did have a CT scan, and it can ultimately lead to better quality and quicker decision making.
Yeah.
Yeah, I've heard the term using AI to reference augmented intelligence rather than artificial intelligence, which is the standard, of course. But when you talk about it in that support role, it's augmenting the clinician who's making a decision, which I really like.
Yeah.
Like that.
Great. Awesome. And regarding the Kenya app, I think I saw that video on YouTube.
Oh, did you?
Yeah,
Yeah,
I think
yeah.
there's one. Yeah, go check out. I mean, one of the overarching goal for the RISE conference and the Health AI Forum is to bring researchers and industry and business partner together to talk about innovations. I mean, what do you see as the industry and the partners? Like, what do you see the role as researcher and academia? What kind of a role we play? In terms of like innovation and to make sure the rural health innovation they are evidence based and are have measurable outcomes. Do you see any sort of? I would like to hear your thoughts how we can improve the collaboration going forward.
I can start.
Yeah.
So
Mhm.
it's interesting being a private company. It's difficult for us to collaborate, directly with a payer, directly with a retailer, or or other entities with governments sometimes. So one of the roles universities can play, I think, is as a convener, bringing us all together here to have these conversations. You can convene through and bring people together through sort of spearheading efforts
Yeah.
to bring other partners together. Sometimes I think from our perspective, it's a little bit easier to partner and support folks. And then I think the other way is just from the rigor around the evidence generation, the data collection, doing randomized controlled trials, getting the evidence so that innovations can be funded in the future,
Yeah.
and sort of keep that whole innovation flywheel spinning.
That's
So
awesome.
Yeah, I would echo the evidence based. I mean, driving towards outcomes, measurable outcomes, actionable information that we can actually do something with, not just dump a bunch of money into activities and go do things and then not really know what works. Not just from a business perspective and which products work, but when we think about policymaking and we think about where government dollars are going, before the panel started, we were talking about and I think it was mentioned earlier, the rural health transformation, $50 billion.
Yeah.
If you don't think every state is clamoring, I know you guys are working on the Indiana proposal, that's a lot of money just being thrown out there, right? And we need to see if all of these ideas and the ways that that money is being spent, which things are working and which things are not. And if they're not working, fine. Like we learned something, right? But if they are working, let's double down. And the only way we're going to know that is through good, solid research and the right methodology and unbiased. And I mean, there's a lot of incentives out there to show that something is working when it may or may not really be working, because that just means you'll get more money. So having unbiased, academic, valid methodology for this outcomes research, I think is going to be really, really important.
That's good to know. Yeah.
I agree with those comments, and I would just highlight the role as the convener. So this is probably my 3rd or 4th time coming to this conference, and I really enjoy the cross-sector collaboration. Every time I come, I meet people from different industries that show me a different way of delivering healthcare, and we bring back many different ideas to our plan, and I think that's the value of having this academic setting. In fact, we've talked a little bit about a maternal health effort that many of us were engaged in a couple years ago that brought together CareSource, which is a health plan, Notre Dame, which is an academics, Kroger, and these entities that don't normally talk to each other coming together to address disparities in maternal health. I think that's the value of being in this environment, and I think that thought leadership that academic institutions can bring, is really, really valuable.
That's great. That means we have to have this RISE conference next year. All right. So I have a specific question for you,
Yeah.
George. And you work globally on health equity and workforce strategy, and you have seen a lot of things like around the world.
Mhm.
Like any lessons you see from other countries in terms of technology use and data can be applied to strengthening the rural health innovation in the U.S.
Yeah, there's a specific example I wanted to share with you guys. I mentioned Penda Health, which I talked about in another example, but there's one innovation which I think is really cool. It's from a very distant land called Texas, and so they were funding a company there called Hamilton Health Box, which is a really cool startup company. They've developed what they call a micro clinic that they can set up in 60 days in any rural location in the U.S. And they've started in Texas. And what they do is it's a very small footprint. I think it's like 15 feet by 30 feet. They bring it in sort of prefab. They set it up, they bring in a high-speed internet connection, and then they can have someone like a health assistant. It doesn't even need to be someone as highly trained as a nurse, can be the only person that manages that box. People will make appointments, they come up for primary care, the health assistant is there, they can work all of the diagnostic equipment, the primary care physician is beamed in via Zoom or some Zoom-like technology, right, via high speed. The patients get high quality primary care from physicians that could be anywhere in the US or anywhere in the world. And they're bringing access to very rural locations all over well, all over Texas at this point, but they are expanding. And this is a really cool innovation where, if you just sort of if you think outside the box, there are really innovative ways that people are using to get care to people that need it, and it addresses a couple of different issues. One, it addresses the lack of healthcare workers
Yeah.
in those locations, the lack of healthcare workers overall we've talked about that is going to be an issue, and then again, just trying to close those health equity gaps across the U.S.
That's great.
Yeah.
Yeah. Good lessons. I have a special question for Lynn. I mean, we sort of like touch on those points before. If you feel like I'm being redundant, feel free to come up with a question that you answer yourself. So like as a practicing physician and now a chief data officer, and you are sort of in a very unique position to address how AI can be used to bridge the gap between there's a data available in rural health. There's also data now actually being used. There's a sort of a gap in there. Like, do you have any sort of ideas how to bridge the gap?
Yeah, I did mention it a little bit. I think it's, one of the things we're focused on is really making sure decision makers have the information they need to make good
Yeah.
decisions, as I said before, whether it's a payer making good value-based care decisions or plan design, formulary, all those things, or a physician at the point of care making a decision. And we're really leaning in to help patients have more information when they're making decisions. Like, having a patient understand what is the cost of a medication. Are there different prices at different pharmacies? Patients don't even know that. They don't know, should I use my pharmacy benefit or should I look at GoodRx, or is there a coupon available? So, getting that data into the hands of the people who are making decisions sort of as a push. And then also, we're leaning into using data more than we ever have to derive insights that then generate action. So,
Yeah.
doing more analytics on the data, doing more predictive analytics, doing more automation of decision making for clinical decision support, those types of things to help just, you know, reduce the friction in the system, help give better quality decisions, and use the data that is available, better and
Yeah.
more, and really taking advantage of it. And the caveat I will put in there is that this is all being done on a foundation, which was mentioned many times this morning, which I loved, of absolutely rock solid data governance, privacy, security, respecting HIPAA, respecting our contracts with our partners who may or may not give us the data rights to do these things. The foundational data governance and all of the proper permissions to use this data is also really, really critical, because this is patients' health information. You can't just go dig around and do whatever you want with it.
Yeah, yeah, right. That makes a lot of sense. And finally, for Cami, I'm sorry. So, I mean, you work in healthcare, CareSource for quite some time, and we mentioned about like using AI to do the cost management and kind of stuff, and proactively, what do you see that AI can be used maybe to identify and support patients in the rural area with complex social and medical needs?
Thank you for that. So I see using AI as a continuum, if you will. The first I like to call description. So, what does the population look like? There are several rural counties here in Indiana, and first, what do they look like? What are the demographics? What are the ages? What are the ethnic backgrounds? What's the disease burden? Those sorts of things I think are really important. I think that data can be collected, and then AI can be used to just kind of describe that population. The second thing I would call prediction. So, who needs what? As a health plan, we cannot touch every member. So, we really need a way of prioritizing what members need outreach, what type of outreach, what frequency of outreach. And so, we use AI to leverage predictive analytics and really taking that data to prioritize who needs that outreach.
Yeah.
And so I think that helps us be more efficient, it helps us be more targeted, and it helps us make sure that we're getting the needs met of those who have the greatest needs. I think the next thing is intervention. So we know who needs things, but what are those things? So we can use tools like geospatial intelligence that can say, okay, here are the members with diabetes, here are the pharmacies, here are some of the other things that they may need in order to manage their condition. And again, that AI tool can really help us determine what resources are most accessible to that individual. And I think that's critically important in rural areas where things are sparse, transportation may be limited, and there may be other barriers. It also lets us know, hey, it doesn't appear that there are resources. So we've determined that you have a lot of individual COPD. There's no pulmonologist for 2 hours. Now we need to consider, is there a telehealth option? Is there a teleconsultation option? What other interventions could we potentially use to help close those gaps that we've identified? And then last, but certainly not least, is what I talked about before is outcomes. So we really want to be able to put all of that information together and make sure that we're not just making ourselves feel good, but we're actually moving the needle for those members and that community. And so from a health plan perspective, those are all the ways that we find AI to be useful. One other thing that's outside of the member journey is efficiency of our staff. So we talked a little bit about that with the care management team, but even with those people like myself that aren't member facing, we have our version of Chat GPT, CareSource GPT, where we can put, more proprietary information in that just helps us move through our days more efficiently. And I think that all helps us do a better job for our members.
Yeah, for sure. Yeah, I use ChatGPT every day. So,
So do I.
so we have about 2 minutes left. So we're gonna open the floor and to see if the audience have any questions. Yeah, we do have one there.
So we're all comfortable with data and value data, but I'll give you a personal experience. My husband was in the most intense ICU for 6 months at Cleveland Clinic, and I followed all the data on all the monitors all the time, and I was a pain in the ass saying, what's going on. If you could provide, for instance, in a family lounge or anywhere, have AI answer, what does this mean to you and why should you care?
Mhm.
If you could add those parameters to people who don't know or value data or know nothing about the healthcare system, you would move mountains.
Yeah,
Wow.
I love that. What was not part of my bio, which is, I was looking for a way to sneak this in and I just found it. I'm not only a proud Notre Dame alum, I'm also a proud Notre Dame mom. And I have twin daughters who graduated from here a little over a year ago. And one of them was in the ACMS program. So she is also
Oh.
a statistician. And when she was going through the program and we were doing some work with the Notre Dame master's program in data science, what I loved about the master's program here is that it pulled together the academics of data science, right? You've got to have the solid technology part, the ethics of data science, which is what we're all doing here, but the third pillar of it was communication. And I loved that. And shout out to Roger Woodard, who was putting the program together, that the communication of how you take data speak and turn it into real language for real people who are not data geeks like those of us in this room and don't read spreadsheets and understand natural language, if you will. How do you translate the insights of all this amazing technology and analytics we can do into something that a real person who has to make a clinical decision or a business decision or a real life healthcare decision for a loved one, it has to be turned into something that real non-data people understand. So that's really, really important. And I love Notre Dame's focus on that. I love that Notre Dame focuses on the ethics and the real world implications of this data. It's not just a science experiment. It affects real people's lives.
Okay, we have a. Oh, sorry.
So I just want to say thank you, ditto, 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 on that consumer part. So I actually have a kind of like a two-part question. So all of this is really, really wonderful, but I think there are two things that we need to add to that consumer perspective. So first of all, everything we do in healthcare is designed around the clinical perspective and the clinician. But where is the data set that actually understands what happens to you at home? So every time, I mean, it annoys me. I'm an emergency doc by background with 20 some years, and I saw lots of people coming in because no one thought about how they were living at home. It's a great barometer of the community setting. So in our discharge and care managers, where's the systematic to say, how many steps do you have? Are you a solo ager? Do you actually have care at home? If so, what is the time burden? And are we actually measuring that stress index, if you will, on the caregiver and family to actually execute on the duties you have? The average caregiver spends about 20 hours a week managing care. You talk about this administrative support and simplification for the providers. What about for the consumer? Some 25% of consumers stop seeking health care because the administrative hassles of scheduling, getting coverage eligibility, and all of that becomes such a barrier, they stop to begin with. Which leads me to the last part, which is trust. All of this, we can make the most beautiful systems, but if they are not user friendly, administratively simple, user experience focused, they're not going to get used. And if they don't build trust, the Edelman that does trust surveys on an annual basis, there are a couple of numbers in there that really scare me. First is in their 2025 health survey, 61% of adults in the US actively believe that institutions, NGOs, media, government, business are actively intervening to prevent me from getting quality care. Anywhere from 25 to 35% actually get their health information from non certified healthcare providers, whether it's through social media or through friends and family. Some 40%, this is global, not US, some 40% believe in violent activism, which means deliberately spreading misinformation, deliberately attacking people online, deliberately destroying property, and deliberately actual violence. And we're seeing a lot of that coming out. Unless we think about how we build that trust back. And the good news is there's one little positive thing, which is you can earn, and get in this health survey, you can earn my trust if you understand me, people like me, and understand my pain points. So I feel like that's a little missing because we understand the pain points of providers and the health system. But what about the pain points of the consumer, family, and caregiver, and building that data set into making AI more robust and more trustworthy?
So I couldn't agree with you more. And I'm going to go back to you always need a human in the mix. So the one potential solution that I see to much of what you describe are community health workers, which was brought up earlier. When you talk about what does the home look like, I'm reminded of a story of a person who was not adherent to their medication regimen. And finally, a community health worker went to visit and discovered that the individual couldn't read. And so obviously they weren't adherent to their medication regimen because they couldn't read what was on the bottle. That's not something that oftentimes comes up in a visit, and AI is probably not going to pick that up either, although maybe. We still have to have human beings in every part of this system, especially when you're talking about trust. Some communities are less likely to be trusting of the healthcare system than others. I think that having people with shared life experience can really help overcome some of those trust hurdles, can show individuals how to use technology, can help with the credibility of that technology, so that we can get to where we are. But I think there always going to be a need for humans.
Yeah,
All right.
I love your question. I just want to add one really quick thing. I love your question mostly because I spent the last 5 years of my clinical practice in hospice care, where I was going into the home. And I went into homes deep in East St. Louis and deep in very rural communities, very dangerous urban communities, and nothing gives you perspective of what's really going on with a patient until you see them in their own living room. And AI is not going to fix that, right? Nor should it. And, we talk about having a human in the loop, particularly in healthcare. And I would say we need to keep humanity in the loop in healthcare as well. And that's where it comes to you are still human beings, treating human beings, caring and connecting with human beings. And AI and data can be an amazing tool for that, but it cannot and should not ever replace that human taking care of another human.
Awesome. Okay. Thank you so much, all our panelists, for the wonderful discussion.